Yeah, so now I'm going to talk about the oncolytic virus therapy, which is the part I missed during my presentation. And so first, I would like to talk about the concept. The concept of oncolytic virus is just very simple. So we introduce some oncolytic virus, which the genetic materials is well modified for the purpose to kill cancer cells, and they will trigger and induce tumor cell lysis. And subsequently, we'll have a lot of interaction like the local inflammation to destroy the tumor microenvironment and releasing the virus progeny so that more tumor cells could be infected. And we also utilize the immune system. By the release of tumor antigens, we could induce and trigger the systemic anti-tumor immune response. So there's a lot of challenges of the oncolytic virus therapy. The first would be the hepatic sequestration. So due to the binding between the fibronop domain of the virus and the plasma proteins of the cells, we will have a uptake in the hepatocytes. I mean uptake, I'm talking about the virus. So they have a HSPG pathway and the hepatic saturation, which means this interaction with the liver is actually detrimental. And we have to think a way to evade the hepatic sequestration, avoiding the interaction between the virus and the liver. So we also have a lot of room for improvement. So we would like to modify the virus so that they could have an increased oncolytic activity and improve the safety in the clinical settings because they are virus. We will also have the desire to increase the cancer targeting to achieve a selective delivery. For the last part would be the immune response. So because it's virus, just as you get cold when you have some virus running around in your body, like when the virus is delivered to the cover cell, the dendritic cell, macrophage in the liver or spleen, the innate immune reaction will be triggered within hours because the viral component is recognized. They will have some pattern recognition receptor in the cells. So the solution to all of this is the genetic engineering. So I know this graph may seem very complicated, but actually it's just a demonstration and an easy example to demonstrate the transductional targeting by using a lot of genetic modification techniques. So this is actually why the oncolytic virus therapy is regarded as the gene therapy, because we do a lot of genetic modification trying to tackle the challenges we proposed and demonstrated before in the last slide. So starting from the left, you can see the E1 gene. So what's the E1 gene? It's used to induce oncolysis. So you can regard it as the killer gene. So, and then we have the deletion of the RGD sequence to increase the cancer targeting and suppress the tropism. So the third one would be the replacement of the HVR, the hexon. So it is used for the targeting. When we are talking about targeting, we would like to increase the binding, the interaction between the virus and the cancer cells. But we would also like to reduce the interaction between the virus and the normal tissue. So we would have a detargeting function to inhibit the interaction with the coagulation factors to reduce liver infection. So the E3 gene is the marker gene used for visualization. So for an example, we have the enhanced green fluorescent protein. So it could help us to visualize the gene. And you can see there's a mutation in the AB loop of the fiber. Also have similar purpose for the deletion as the deletion of the RGD sequence to increase the cancer targeting and suppress the tropism. And the last one would be the targeting ligand to insert the targeting ligand into the loop of the fiber protein to increase the cancer targeting. So actually, it is a very, very effective way to increase the cancer targeting just as the deletion of the RGD sequence. And the last one would be organ-specific mRNA complementary sequence, the E4 gene. So the E4 gene is used to reduce the normal tissue damage, to reduce the side effects. So as you can see, the replacement of the HVR and the E4 is actually to spare the normal tissue, and the deletion of RGD mutation in the AB loop and the cancer targeting ligand is actually for the killer for cancer targeting, and the E1 gene is the killer gene. Yeah. So the problem being that we have no idea which ligand to choose for specific targeting. So what we are trying to do is we create a adenovirus library, a lot of different type of adenovirus, and then we select the most desired one, as you can see from the left. So we have a oncolytic adenovirus with the oncolytic gene incorporated in their genetic materials, and then after creating the library, we extract one of the desired adenovirus and extract the pancreatic cancer targeting ligand, and then we combine and merge them together. So now we have a pancreatic cancer targeting oncolytic adenovirus. So we use ultrasound and CT to guide the injection of the virus through a percutaneous pathway to inject this adenovirus, and then we achieve the local control to improve the resectability. So the further improvement, we can do a lot of things. As you can see, I talk about the HI loop, the fiber. So what I'm actually talking about, so here I'm talking about. So if we would like to further improve the cancer targeting, we could use the fiber switching. An example is the 8535. It is specifically exploiting the CD46 receptor for cell infection because there is prone to have a high CD46 expression in the cancer cell. And the 8311P fiber could increase the selectivity for colon cancer. Another improvement we would like to achieve is to reduce the native tropism. So we talk a lot about oncolytic virus therapy. Is there any FDA-approved drug? Yes. This one is using the HSV1 for the virus, and it is used to treat a resectable melanoma recurrent after initial surgery. So as you can see, it has a local effect, which is the tumor cell lysis, and subsequently followed by a systemic effect with a tumor-specific immune response, because the lysed tumor cells will release a lot of signaling particles to induce the immune response. So the advantage, there will be a lower probability of therapy resistance, and there will be multiple oncogenic pathway. So as I've shown to you before, there is a lot of genetic modification to increase the cancer targeting. So we have multiple methods, means. So the third one would be the amplification of the virus particles with time in the host, which means comparatively to traditional chemotherapy, which the concentration of the drugs keep dropping, the therapeutic effect of the oncolytic virus therapy keep rising because the virus keep replicate. And the fourth one would be the selective replication. Fifth one would be the non-pathogenicity, which means the virus is not inducing any disease because we try to remove every harmful stuff, harmful gene by the modification. So the last one would be the room for modification. We could have just as I demonstrated, the fiber switching to increase the safety and efficacy. So for these advantages, some of the patient may have the anti-oncolytic virus antibodies against this virus to limit the therapeutic effect by using this approach. And due to the physical barrier of the solid tumor, if you are treating solid tumor, there will be limited efficacy, or there may be limited efficacy for tumor showing heterogeneity. After the certain time of injection of these viruses, we should expect there will be a generation and creation of the antibodies against this virus. So they may be reduce the therapeutic effect, and it's one of the concerns we would like to address. So the liver sequestration I've been talking about all the time. And lastly would be the affinity to serum protein and instability. So it may be unstable, and we would like to tackle this problem in the future. So this would be the part I'm missing, and I would like to present to you if you are interested in this topic. Actually, I would like to say that gene therapy is a very, very huge topic. Like even the previous part, I've skipped a lot of the content. As you can see, I'm like rapping in rapid speed. So I hope to have another chance so I could dig deep or present more about the various aspect of gene therapy. But I'm not gonna like provide more presentation about the previous parts, although I've skipped a lot of details and context because I'm afraid that they may be confusing. Thank you.